Hello everyone, Dr. David Warmflash with another flash moment in medicine and medical science. Hey, if I were to tell you that there's a 65-year-old man with a long history of smoking, he's overweight, and he's feeling chest pain, feels like an elephant is on his chest, and he's dyspneic, and he's diaphoretic. Well, you could probably, before even examining him, have a really good idea what it might be. You might think, oh, he might be having a STEMI, having an MI. But what if you were to get, let's say, a whole family of people, a mother with a couple of young children, and they all, well, we don't feel that great. We have headaches. We're a little nauseous. Oh, feeling a little bit groggy, not so up to speed with everything. It may not be that clear. And that's what happens often in carbon monoxide poisoning, CO poisoning. You really can't be sure just by the symptoms alone. So you have to really get down to what the situation, the environmental situation, what led to it. So what's carbon monoxide? CO. Carbon monoxide is what you get with the incomplete combustion of hydrocarbons, of anything. So you don't combust all the way to CO2. You only end up with CO. And that makes the molecule very sticky. It can actually replace oxygen, molecular oxygen, on heme proteins. And that can include hemoglobin. The heme proteins don't only include hemoglobin in your red blood cells, they also include a whole bunch of other proteins that carry oxygen or carry electrons. So in different tissues, they have their own type of special oxygen storing molecule. Myoglobin in muscle tissue, neuroglobin in nervous tissue, and so on. Now, what about inside the cell? Well, you got the different cytochrome proteins inside the mitochondria and the electron transport chain. There's the cytochrome oxidase, and carbon monoxide can interfere with that. How does this work? What's the pathophysiology of it? Well, hemoglobin, let's use hemoglobin as the example. That is a 4-chain molecule, and it's an allosteric enzyme. It's an allosteric molecule. What you do to one chain has an effect on the other chains. Remember, in hemoglobin, you've got 2 alpha chains and 2 beta chains. Every chain has a heme in the middle, and that's the site for binding to molecular oxygen, O2. 4 oxygen molecules can attach to hemoglobin, but CO will attach with 240 times the affinity that O2 will attach to hemoglobin. That is a real problem if you get exposed to carbon monoxide. What it does, first of all, is the CO2 occupies O2 binding sites, so you cannot carry any O2. Does any oxygen simply get dissolved in the blood? Yeah, a little bit does. A very tiny, tiny proportion of oxygen carried in the blood is not bound to hemoglobin. It's simply dissolved in the aqueous medium of the blood. But it's really, really tiny when you're under normal circumstances, meaning when you are, as I am, here on Earth at the surface, very close to sea level, where the atmospheric pressure is 760 millimeters mercury. That's the total atmospheric pressure. Most of that, about 78% of that, is molecular nitrogen. That's N2. But each gas has a partial pressure. And the partial pressure of O2, when you're at sea level, it's about 160 millimeters Hg. So it's about 21% of the air, of normal room air or outside air, when you're at sea level. And that has a hard time competing with something that is 240 times as sticky onto the hemoglobin molecule. And it's the same thing on other heme proteins. The relative affinity isn't exactly the same, but it's basically that. It will stick a lot more strongly to these other heme proteins. So if we're talking about the electron transport chain, we're talking about interfering with cellular respiration. That's where pairs of electrons get passed down the chain until finally they get accepted by oxygen and you have water at the end. Well, what else does it do when let's look at hemoglobin in this case, when you have CO bound to hemoglobin? Well, remember we said that there are 4 binding sites, 1 on each chain of the hemoglobin molecule. But let's say you don't have all of the binding sites bound with carbon monoxide. You can have some of them with carbon monoxide and some with oxygen. And what it will do is it will actually make the entire molecule more sticky also for oxygen. So what it does is it shifts the hemoglobin binding curve to the left. And that means for oxygen. So not only will it occupy spaces, but any oxygen that's on there will have trouble getting off of the hemoglobin molecule, unloading into the tissues. That's really bad too. As long as we're talking about the curve, let's talk about a few other things that would shift the curve to the left. To recall what makes the curve go to the left, just think of it as in terms of the process. This is what causes it to carry oxygen, to take hold of oxygen rather than to release it. And that's what will happen in places like the lungs, where you would have conditions that you want to cause oxygen to come onto there, okay? So it would not be something like acidity or a high concentration of protons. You would be, in other words, not a low pH. It would be a higher pH, an alkaline environment. It would also be a lower concentration of BPG, bisphosphoglycerate, meaning there's been less metabolism going on, you're less depleted, so that would be a time to grab on to oxygen. Those kinds of things shift the curve to the left. Take in oxygen. What would shift it to the right, besides for a lack of carbon monoxide? Well, the opposite. So things like an acidic environment. So if there's metabolic acidosis, or even if the pH is just a little low, as happens in tissue that has depleted its oxygen supply, well, the curve will shift to the right. Higher levels of bisphosphoglycerate, for instance, higher temperature, just like lower temperature would be another thing that we didn't mention that would shift the curve to the left. How do you diagnose it? Now, normally, to assess somebody's O2 status without being invasive, you use a pulse oximeter device, just a simple device that goes on the finger or on the earlobe, and this will tell you the percentage of hemoglobin that is saturated with O2. It's the SpO2, the hemoglobin saturation. Now, how does pulse oximetry work? It works with light. It uses the normal pulse oximeter uses 2 wavelengths of light. There's a 650 nanometer wavelength, which is in the red part of the spectrum, and there's a 940 nanometer wavelength that is in the near infrared. And the reason it does that is because deoxyhemoglobin, which is hemoglobin that's not holding oxygen, and oxyhemoglobin, which is hemoglobin that is saturated with oxygen, they have very, very different absorbances between those two wavelengths. And then based on the difference between how much of the 650 nanometer light is absorbed and how much of the 940 nanometer light is absorbed, you could tell how much what percentage of hemoglobin within red blood cells in the arterial blood is saturated with oxygen. It loses its accuracy when it gets down into 70% or so, which is what venous blood is anyway. Now, how does it tell the difference between arterial blood and venous blood? It's actually a very kind of smart invention. It uses methods involving the light detecting diodes, not only to account for background light in the room, but also to account for it uses a whole algorithm with all this to account for differences between what you would expect from arterial blood during pulsation, during systole, versus diastole. In other words, that's why it's called pulse oximetry, and it's a fancy algorithm, and the machine knows how to calculate it. Now, the problem with relying on this for carbon monoxide poisoning is it won't work, because carbon monoxide occupies hemoglobin, and if you're only using the basic pulse oximeter, which uses those two wavelengths of light, it can't tell the difference. So it's going to tell you your hemoglobin that you're 100% saturated, when actually a lot of that, depending on how bad the CO poisoning is, a lot of that will be actually carboxyhemoglobin rather than oxyhemoglobin. So what you need to do when there's a suspicion because of the clinical situation and the history, if let's say you have a patient or a group of patients that came in after a fire, that's a common way that it happens. Tends to happen more often in the winter because of people using heating ware and do-it-yourself heating type things inside. Also cooking inside, barbecues inside, things like that. There's also industrial sources, and there's also a good number of these are suicide attempts. Someone goes in the car, puts the engine on in the garage with the windows open. In the United States, there's something like 50,000 visits to the emergency room that are due to CO poisoning, and about 20,000, 21,000 of those are from accidental CO poisoning. And then there are also types of industrial situations where it's not CO that the patient breathed, but something else, and the liver will convert that into CO, such as paint thinners and things like that. So if there's a suspicion, you just can take the normal pulse oximeter and throw it away, and you have to use a special pulse oximeter, which is CO oximetry, co-oximetry. And the way that works is instead of having just the two wavelengths, it has a whole bunch of different wavelengths that it uses, and then it is able to tell the difference. And it does a calculation, and not only can it distinguish out carboxyhemoglobin from CO binding to hemoglobin, it can distinguish methemoglobin, so this could be extremely useful. Some other things you need to keep in mind: if the patient came in because of a fire, you also have to check for cyanide poisoning as well. Now, there's a whole bunch of laboratory tests to do. We won't go through all those, but you do have to evaluate the cardiovascular system, evaluate the brain because of if there's fogginess or some issue of consciousness. You have to rule out other things too, but you want to do also arterial blood gases to look at the really to evaluate for metabolic acidosis. Uh, Measuring oxygen, which is part of the ABG exam, that actually won't tell you that much, because what that is measuring is the it's based on the partial pressure of oxygen dissolved actually in the blood. So it's not there's that tiny bit of oxygen that is in the blood itself rather than being bound to hemoglobin. But that can be important because you actually can get a significant amount of oxygen dissolved in the blood itself. So if you put the person under extremely high pressure oxygen, I once saw this happen in a hyperbaric laboratory where they were able to keep rabbits alive with no hemoglobin at all, completely, fully anemic rabbits alive at a atmospheric pressure 3 times the normal atmospheric pressure. So 3 atmospheres of 100% O2. Now that's going to come into play in a little bit when we talk about the treatment. But the first line of treatment is not hyperbaric oxygen. It's just 100% oxygen, your normal sea level pressure, but at 100% oxygen. Now, how does that work? There are different ways to oxygenate people. You cannot really get to 100% oxygen by using a simple nasal cannula. That's the tube that goes into the nose. On the simple cannula, you get about 3 or 4 percentage increases in the percentage of oxygen from the amount in room air for every liter per minute of oxygen that you supply, and it can only go up to 6 liters per minute. And what that means is that if your normal percentage of oxygen at sea level is 21%, partial pressure about 160 for O2 millimeters Hg, and if you go just 1 liter per minute, you're going to get up to something like 23, 24, 25% oxygen. And if you go up as high as you can go, the highest flow, you might get into the low 40%. You can get higher by using different types of equipment. You can have a face mask, not a simple face mask, but there are a Venturi mask can get you to the realm of about 60% O2. Non-rebreather mask can get you to something like 90%. And then there's high flow nasal cannula, which can get close to 100%. The way that works is it moisturizes the air, so you don't have the effect of being able to of drying out after a certain flow rate, and you can get to much higher flow rates that way. But there's also CPAP can get you to 100%. You don't have to go this far, but there's also invasive ventilation. Now, this is good only to a certain point if the CO poisoning is moderate or mild. But otherwise, if it's really bad, like above 25% carboxyhemoglobin, or if there's certain risk factors, any kind of pulmonary disease or cardiovascular disease or other risk factors of the person, or it's a pregnant woman, a bunch of factors like that, you're going to want to go to the best kind of treatment, which is more than 100% O2. You can't do that under normal circumstances. You need to increase the pressure, and that means you need to go to hyperbaric oxygen therapy, a HbO2, and you need special equipment for that. There's got to be a hyperbaric chamber, so you have to know where the facilities are that have hyperbaric chambers. They're not everywhere. Every emergency room does not have one. Now, the different types of chambers, there's a uniplus chamber, which is a kind of, it looks sort of like an iron lung from the days when the polio patients in the early to mid 20th century would lie down in this metal contraption, except the head doesn't stick out. The person goes inside it completely, and their little hand inserts for people to work on the patient. But there's also multiplus chambers where you can have more than one patient in there, and medical personnel can go inside the chamber with the patient. So that's an even better thing to have. Now, what happens in HBO2 is that the atmospheric pressure is brought up from the normal 1 atmospheric pressure to 2 atmospheres and above 2 atmospheres. It can go up to 3, but usually they go somewhere to about 2.5 times the normal atmospheric pressure. There are different protocols. In the United States, they mostly come from the U.S. Navy. They have Navy protocols because this treatment is also given for diving accidents, for things like arterial gas embolism from a diving accident, which requires the highest amount of pressure and for the longest amount of time, and also for decompression sickness, DCS. Now, what happens in that high pressure is that, first of all, the pressure goes up at a kind of medium rate. They get it up pretty quickly, but not super quickly. And then it kind of stays at a certain depth equivalent. It's the pressure that you get at a certain depth. So you'd get to about 2 atmospheres at the equivalent of something like 10 meters of depth. And for most of the time, the people inside the chamber, the patients in the chamber at least, are breathing 100% oxygen at that new total pressure. But there are some breaks. There are these oxygen breaks where they kind of drop down the oxygen level, because this is going on for a couple of hours or more, or even a few hours, depending on what the particular protocol is. And the protocol is known as a table. They're called the dive tables, and they're called pressure tables. So you have like Navy table 5, Navy table 6. And if it's a multiplus chamber where you've got the healthcare people going in, they're not breathing 100% O2. They're breathing the normal percentage of O2. So they're getting a little bit more O2 only because they're getting more pressure overall. But inside there, the patients have hoods over their heads. So in addition to having the higher pressure, whether it's 2.5 atmospheres or something like that, they got 100% O2 at that pressure. And then gradually the pressure is brought down, a lot more gradually than it was brought up, because you actually have to avoid decompression sickness that you can get from nitrogen bubbles that can build up from those times when you're not breathing 100% O2, but you're breathing a little bit of nitrogen, or also because of the personnel who are in there not breathing 100% O2 the whole time. Why don't you want everybody to just breathe 100% the whole time and not take air breaks, or just not have the personnel just breathe 2.5 atmospheres of O2? Well, because that's toxic to the lungs and you want to minimize that. So you go through the protocol, and the idea of the hyperbaric chamber, yeah, it could keep a person alive for a while by allowing the blood itself to carry the oxygen just dissolved in the blood. But that's not really the reason of why you do it. That's an added benefit. What it's doing is by getting that oxygen in there at extra high pressure, then it finally can outcompete the CO and start to eliminate the CO from not only from those hemoglobin molecules, but eventually also from other heme proteins, all the way down to inside the cell. So at that point, we're not talking about CO being 240 times stickier than O2 anymore. Now you're able to change that ratio, and that's how you can get rid of the carbon monoxide. And that'll be it for today's lesson.